My name is Kelly Sittig. I have the pleasure of serving as the Executive Director for the Iowa Cancer Consortium. My pronouns are she and her. Thanks for being here today. For those of you who may be slightly new to the consortium, I'm going to give you just the tiniest bit of information. We all know that cancer is really costly. It's a costly disease. It's complicated, which means that it's really hard to address alone, especially on a statewide scale and ultimately national and global scale. And that's why the Iowa Cancer Consortium exists. We are here to bring people together to build a network of people who are working in or advocating for cancer in some form within our state here in Iowa. And so with all of you here, this is an opportunity for you to build your personal networks, for the consortium to build its network. And ultimately, this is really what we're trying to do with the clinical trials roundtables. I get to introduce our great speakers who are active and wonderful Iowa Cancer Consortium members, Lori and Shannon. So Shannon, I'm going to start with you. Shannon is the administrator at the Iowa Oncology Research Association. She is also co-chair of the Iowa Cancer Consortium Research and Clinical Trials Work Group. So she gets to play double duty today, being both a co-chair and a presenter. And Lori is the Cancer Services Director at St. Anthony Regional Hospital in Carroll, Iowa, and we get to hear about this wonderful partnership that they developed and how it led to providing clinical trials in a rural Iowa hospital. Shannon and Lori, you are up. Thanks for being here.
Thank you, Kelly, for that nice introduction. One thing I want to add to my bio, and I didn't want Kelly to say this because it's part of what I want to say to everyone, is I am from a very rural farming small community in southwest Iowa. It's called Mount Ayr, Iowa, and that's where I grew up. And the nearest Walmart for us was about 40 miles. And so my goal as the administrator of a community oncology funded program through NCI is for people that live in a town like I grew up in. I want it to be easier for them to go on a clinical trial than to go get a pair of pants, to get a pair of jeans. That's what I want, because really, if we're the clinical trials that we do at the organization that I work for they're not trials in Des Moines. They're not trials in Iowa. These are national trials. And so if we really truly want good data, we really need to be representing the whole state of Iowa and turning that in. You know, I can tell you that the way that people, the hobbies, the food practices, the exercise habits, all of those things for where I grew up are a lot different than where I live now. And it's just culture. And I think it's important to, you know, again, if you want accurate data, if you want meaningful results, which is what we need to be including everyone in clinical trials. So that's why I think I'm really excited about what Lori and I were able to accomplish. Just a little bit about my organization. So Iowa Oncology Research Association, we're housed at John Stoddard Cancer Center, but we're a private corporation, and really any physician who wants to do the training can become a member of our organization. And once we have a physician member, that's what we really need in order to enroll people to the clinical trials. So there is a process, but if you're on this call and you're, you know, our hope is that the takeaway is that you realize, well, A, it's doable, but B, it's important. And, you know, really with just a few pieces, you can make this happen. So I think that I'm going to let Lori share a little bit. We're going to kind of go back and forth, but I just wanted to give the introduction about the pants because I think that's meaningful and I think that people understand that. So.
Thank you, Shannon. Like Kelly had said, my name is Lori Pietig. I'm the Director of Cancer Services at St. Anthony Regional Hospital here in Carroll. And, you know, I have to kind of mimic off of Shannon's conversation is that I am also rural Iowa, born and raised in a community and a location where we have very viable, accessible healthcare. And as a state and we have cancer centers also placed in those very viable areas, and we can bridge some gaps and provide opportunities to patients that they never thought were available. Our journey in cancer care in Iowa or Carroll started over 30 years ago with a collaboration with Dr. Westberg and the Mission Cancer team. And so we've been caring for patients for such a long time. And this last year, we got the momentum of opening up a brand new cancer center and really focusing and evolving our care model from providing a service to providing a comprehensive service line. And that's bridging all the gaps that our patients may need, and making sure that we're giving them the opportunity in Carroll that they could get in Des Moines or at some of the bigger facilities. And clinical trials was definitely one of those gaps that we could fill. And it was a realistic goal and opportunity for us. And we had the momentum to do that with the opening of the new center and bringing together some key players. Luckily, with Dr. Behrens being one of our medical oncology physicians, he's very passionate about clinical trials and really wanted to start the momentum and introduced me to Shannon. Right when I took on this role, I think within the very first week, I had an email about, we're starting clinical trials in Carroll, right? And I'm like, okay, let's regroup. let's talk about what this looks like for us as an organization. And then we had to pull together just our own internal discussion. Can we do this? Are we committed to doing this? And do we have the key players to do it? And that answer definitely was yes. We had what we needed. And with that, we also had to set a realistic timeline. What was going to work for us was not starting at that very first week I got that email, because we were opening a brand new cancer center. And we really had to strategize our priorities on how were we going to move forward and make sure we were moving forward and being successful. So, with Shannon and Dr. Behrens, I said, okay, let's look at the first of the year. Can I make this one of my new goals for after the center's open? We opened our doors, and believe me, I got an email that very first month of January, and are we ready to start moving forward? And we did. We started that process. So for us, it was first of all starting the conversation with Shannon and her team, and understanding what it was going to take to bring this to Carroll and what we could offer our patients. And one thing I think all organizations needs to have is a key player. If you don't have a point person within the organization to fill out the paperwork, to be a point of contact, to collaborate individuals together, you're not going to be successful. So whether it's an administrator like myself or a clinical supervisor, but somebody to take that on is their task to continue the momentum forward. So conversation and key player, I think those are really your starting points. And that's how you start to understand, is it going to be realistic for our organization? Then we decided that we were committed. We were committed to moving forward, setting those goals and expectations. And then it's about education. So I pulled together a group of individuals. Shannon jumped on via Zoom. So thank goodness for this platform that we all now have. And I pulled in quality management, administration, our pharmacy, our key clinical players. So infusion, our clinical supervisor, our physician champion, which is Dr. Behrens, health information. Anybody who would have questions or would be impacted by a clinical trial in any process, in any part of the process, needed to be at the table. They needed to be able to process the information. How's this look for us as an organization? So we could all collaborate and come together. And with that, we were committed. And Shannon started the process by sending me the information that we needed to get going. And that was filling out a lot of paperwork. So that's where that key player comes into place. It's not challenging paperwork. You've got to get yourself your federal wide assurance number. Some of these things you may already have. And one key thing was working with the Iowa Cancer Consortium, because I needed tumor registry information. It wasn't something that I had, but my connections with the consortium gave me the abilities to say, hey, can you help me with this? I sent them to my forms and they had them back to me filled out so then I could get those onto Shannon. Yeah, overall, the project took us about 5 months to get going. And most of the wait time was just waiting on all of the federal numbers that we needed, paperwork, education, and that got us to where we are today.
So one thing I want to point out, and Lori can speak to this a little bit, is I hope Lori, would you say this has cost you anything so far?
No, just the time and commitment.
So that's one thing. The way that we chose to add St. Anthony to our organization is it's what's called a sub-affiliate site. None of that matters. What I want you to understand and take away from this is you don't have to hire clinical trial staff. We in Des Moines can serve as your clinical trial staff. We can do that through an EMR, through access to an EMR. We can screen the patients that are coming in. We can, complete eligibility. All of this is just done through, strong communication with the physician team, the nurses. If the patient looks eligible, looks interested, we're then working with the chemo infusion staff on how to infuse the drug, those types of things. It's our job in Des Moines, the research staff, to do those pieces of it. So you don't have to, you're not looking at hiring new staff. I mean, you certainly could have that and become a true affiliate site. And we have those as well. So our organization here in Des Moines, we have affiliate, McFarland Clinic is an affiliate site. Both Cedar Rapids hospitals are affiliate sites. Ottumwa Fairfield, we've had Mason City. So we have affiliate sites, but you certainly can look at becoming a sub-affiliate to simplify the process. And really, it just kind of depends on how many. If you're a rural community hospital, you may have a medical oncologist there, just certain days of the week. Well, you wouldn't certainly need to hire staff for that. I mean, it just makes sense to do it as a sub-affiliate role. So I think that's another piece of it. That yes, there is work, lots of paperwork. There are, the physician has to be willing to do the training, which it's definitely not, it's not a huge undertaking. It can be knocked out in a day easily, the training piece of it for the physicians. So I think you just have to have that champion physician or that champion administrator. And then, there are the 4 key items. Lori mentioned the federal wide assurance number, which a lot of hospitals already have. The tumor registry form, there's actually an actual form that needs to capture data on numbers. There's a consortium agreement that needs signed, and that's just boilerplate language from our organization. And then a CTEP institution code, which is actually probably the simplest part. So those are kind of the 4 pieces that have to be done, but they can take some time. Just, the FWA number and the tumor registry form are probably the slower piece of it, but it's totally doable and we can show that.
To circle back with Shannon on the sub-affiliate, that really was the best option for us because they brought the knowledge and all of the tools and policies and procedures. And what we did as an organization was, from a policy and procedure standpoint, was we follow the policies and procedures when doing clinical trials that is set forth by Shannon's organization. We do have a couple of things that kind of overlap with each other, like our chemo spill policy that we have internally, making sure that they're notified, also following, they have a form that's filled out too. So there's a few things that overlap, but we were looking to Shannon and her team to help with the screening process, the education, informed consent. And that way it didn't have to be an additional education for my staff. We just were all knowing that this is going to be happening and that our patients are now going to be screened.
So that, speaking of patients, Rachel asked a really great question in the chat too. She asked, what did this project look like on the patient end? Did they know all of this is happening in the background? And I think that's a great question, both from the beginning of the project all the way through now. Like, how are things going from, well, both from your perspective and from a patient perspective?
I can answer that initially, and then I'll let Lori speak to truly her Carroll patients. But just in a broad sense, and this is, I've spoke at many support groups over the years, and I'm always talking about clinical trials because that's what I do. And when I tell people that if they came through John Stoddard Cancer Center doors, I can 100% say that they were screened for a clinical trial. They are happy to hear that. They feel comfort in that. And so I say you may or may not have known that because there might not have been a trial that you were eligible for, or if there was a trial you were eligible for, the doctor didn't think it was the best option for you. But 100% of new consults that come through our cancer center doors are screened by our research staff. And so, you know, when Lori and I kind of started working together, I was like, this is something that your site will be able to say once we get this all done and we have the protocols up and running, the studies up and running there in Carroll.
So to piggyback off of Shannon, we just have opened up our trials, and we've just identified which trials we will qualify for as a site. So in turn, I'm just starting the advertisement of that, or the communication with the community as we get new patients through the door and the screening process. Shannon, have you guys started the screening of our patients yet?
I think so, yeah, because I know that we have the separate list of what trials are open at St. Anthony. And that's important. I mean, you know, we have in Des Moines, maybe 65 trials at a time, plus or minus 10 probably at any given time. We don't need to open that many trials at your site. We need to open the trials that fit your patient population. You know, I think that's kind of where that tumor registry numbers, where those numbers come in. We try and find the trials that fit your population and that will truly be, you know, ones that you can accrue to. I know that Dr. Behrens right away was like, we're not going to mess around with opening a bunch of heme. We just don't need that. We don't see enough of that in Carroll. You know, he was, you know, wise and knowledgeable about what to open and what would be practical for that site.
And I think really focusing on the patients that we most serve, you know, the colorectal, the pancreatic, you know, those are things that are now open for us. And you know, making sure that our patients are going to know that that's an opportunity for them here. They don't have to overlook a cancer center in rural Iowa that can provide the same care that you can go up to Mayo, and you're going to be screened for those opportunities. And you don't have to travel. We're right here in your community. We want to make sure that they have an increased access to care, that they know that they're getting the best care possible through our organization.
I mean, even in Des Moines, we have patients that will travel to Mayo, and Mayo will call us and they will say, hey, it looks like you have this trial open in Des Moines. I'm going to send this person right back down to you. I think that's, you know, I think they're a good fit for this trial and they want to go on a trial. That's why they came to Mayo. They just didn't know that they could do it here in Des Moines. And so, you know, broadening that and having that outside of Des Moines is really what would be even better for patients.
I'm very excited to make sure that we can make our patients that come here to us are going to get the full encompass of what their abilities are. And, you know, but we also understand what our inabilities are. If there's a patient that could be better served by somewhere else, how do we collaborate with that care? You know, the clinical trial piece is hopefully going to keep some patients here that maybe wouldn't have before, but that we can assist that patient in any process of their journey or any part of their journey. And this is now just another piece of it.
Thank you. What questions do folks have? Again, we want this to be very conversational. We want everybody to learn from each other. What questions are popping up, or thoughts, or how have you done things differently or looked at things differently that we can chat about as a group? One of my favorite facilitation techniques is being comfortable with uncomfortable silence. So I'm going to let it sit for just a moment.
I'm Jim Coulter, and I work with the rural clinical trial activity at the University of Kansas Cancer Centers. And one of the challenges we have had with our smaller sites is biospecimens, shipping, collecting, something even as simple as availability of dry ice. How have you prepared for doing the sometimes mandatory and many times optional biospecimens that you're going to be looking at?
So that's a very good question. We really haven't, I mean, because we are just getting this process started, we haven't dealt with that yet. But I can tell you that the two physicians that travel to St. Anthony, you know, they definitely are familiar with what those biospecimens look like, not necessarily the processing of those, but we as the research team would, we fully know that we would have to probably work with the lab to draw those, send the kit in advance. We're going to be having to send the research drug in same day, getting all that prepared and sending that same day, because that's what the regulations state. So we'd probably have to look at, you know, sending those kits that have, the kits come with the study, and they have, you know, what needs to be drawn in them as far as the processing of them. We have a lab coordinator that does it here in Des Moines. Our medical oncology clinic lab does not process our specimens. We process those in-house and ship them out. So it would have to be something that she'd be communicating with their lab to draw. And if she'd have to travel, she would do that. Hopefully it would be something that they could, you know, if it needs to be refrigerated right away or whatever the instructions would call for, the physician and his staff would take care of those things and get them back to us at the end of the day for us to send out. A lot of things anymore, it seems like with COVID, they've changed some things. There's batch shipments now where we are just, you know, we are storing things, refrigerating and batch shipping things. So I think we just kind of take that on a case by case basis, but that is something that we'll have to look at. And I also think that there's a few trials that may or may not be doable because of that. If it's something that has to be put on dry ice right away, it may not be one that we're able to do at St. Anthony, but we'd work through that.
You know, one thing that Shannon had talked about is, you know, clinical trials are not fast. So when we would have a patient identified and we would start the process and conversation internally, that, you know, we would make sure that we can meet every expectation of that clinical trial with all of the parties that we have at B, you know, the patient, the nursing staff, our pharmacy, if there would be extra labs, or do they need genetic testing? Where do those kits come from? What can be done here in Carroll? Do they need some additional testing done to meet the needs of the clinical trial? That we would sit down as a group as we work through each one of those studies, and as those patients are identified, and making sure that we can meet every expectation of that trial too.
We did purchase those temp tails is what they're called. And that, you know, not only could it work to send the drug, and I'll explain what that is, but it also could work if we were transporting biospecimens back to the central office in order to ship out. So the temp tails are quite wonderful, actually. We just hit a button when we would pack the drug, and it starts taking the temperature in real time every minute. And then, you know, whenever the physician or the nurse or the chemo staff or whoever it is that's going to then get ready to mix that drug, you know, they would hit a button and that would stop the temperature, and it would send us our research staff a PDF of that. So we would have that the full, we can say that we knew what the temperature was the entire time it was outside of our research pharmacy. I bought 3 of those. I'm excited to use them.
Shannon, we should probably touch base a little bit about the clinical trial drugs that come to your pharmacy and how they end up at St. Anthony as a sub-affiliate site, because those drugs are not shipped to us directly to manage, but they come to you and your team, and how the process is to get from point A to point B.
Yep. So everything has to be done day of NCI. That's an NCI mandate. So if it's an NCI federal trial, then we're going to have to, you know, our research pharmacist knows full and well that she would have to get up very early, and she would have to meet the physician and his team. She would have to pack it, start that temp tail, and then transport it to wherever the physician and his team are meeting in order to travel then to Carroll. So I think that's doable.
And then when it comes on site to us, depending on what is going to be entailed for the staff, you know, that's why I brought pharmacy into the conversation. Is there mixing involved? We're in the process of opening up our pharmacy in the center. It's not open yet, but if we have to get that over to the pharmacy for mixing, that team is going to be knowledgeable and know what they need to do. And then along with the nursing staff on the infusion of that drug, and Dr. Behrens or Dr. Westberg would be overseeing that process once that comes to the Carroll site.
Yeah, every single study has a large section of the protocol that details everything you could ever want to know about the drug. So it's in depth, and it's you know, we would, again, because none of this happens quickly, we would make sure that we would get all of that information to the mixing team, to the chemo administration team, you know, probably at least a week ahead of time for them to look through it and find out if they have any questions. See a question in the chat box for Lori.
Yeah, Lori, Susie asks, what does your communication plan and timeline look like? Currently or in the next year, what trials are you planning to participate in? And can you talk a bit about the screening process and finding qualifying candidates?
So the communication plan and just community education is starting first with a radio ad that Dr. Behrens is already on air, letting people know that we're opening up clinical trials here in Carroll. We have a newspaper that comes out quarterly called The Health View. And I'm going to be working to put together an article talking about clinical trial opportunities in Carroll, what it looks like for our patients in our community, because a lot of times it's not necessarily the patient, it could be the support person understanding and asking questions and looking to assure that their loved one is getting all the best care possible. So that outreach is going to cover several counties and all the counties that we serve here in Carroll. And that will start the education and community outreach with that Health View article. As for screening, like Shannon said, her team is going through and working through our EMR and all of our medical oncology patients and seeing who would qualify for our open trial. So right now we've got 1 colon, 1 colorectal, a glioblastoma, a pancreatic, and a CIPN trial open. That's what Shannon had sent me earlier this month, that those are the ones that they decided to start here in Carroll. So it's kind of a soft rollout as we get started, but then that article is really what's going to be the full outreach to all the households that will get that paper.
Thank you. And Anjali, did you have a question?
Yes, I do, Kelly. How did you know that? Hello, everybody. My name is Anjali Deshpande. I'm a faculty member at the College of Public Health at the University of Iowa. And I work with Rachel and with Kelly and with Mary Charlton. And I know, Lori, that you're part of this, that we have a rural cancer work group. And we're very glad to work with the consortium to sort of bring this clinical trials and rural cancer conversation together. My question for you is kind of a weird one. When we think about clinical trials, we think very much about, you know, the doctors and the hospital and what we can do to actually have a trial happen. But my question is about, you mentioned the importance of having a champion at the hospital and whether that's like a key person who's actually doing the work, you know, a champion who wants that work to happen at their hospital. My question is, how can we get this information out to the communities or to other agencies that we work with so that people in the community know that you know, this is a possibility, or maybe this is something that they want to talk to their doctors about and say, well, do we have this option, or why don't we have this option? So my question is really around not just getting hospitals involved, but is there a place to get champions in the community involved in trying to get this kind of access in rural places?
I would think I can speak from the rural setting, is that your champion is going to be your PCP. Your champion is going to be that primary care provider that has built that relationship with that patient. You know, one thing when you think about rural healthcare is that our primary care physicians in mid-levels become that facilitator for care. They're the ones who are going to do the referrals. They're going to ones that, you know, meet with that patient and give them their diagnosis and say, I think that you need to go to X, Y, and Z. It's very different than an urban setting where you get into a large organization and you see 1 million specialists at once and your PCP kind of gets pulled out. In the rural setting, it's not that way. It's the primary care doctors who are being the champion for that physician and building the relationships with the specialist. And they're the ones who are doing the referrals. So I think a lot of it has to come down to those doctors that are seeing those patients and giving that diagnosis and saying, okay, these are options for you. We don't want to overlook this. Make sure you ask them about clinical trials, because that patient is going to take whatever that primary care doctor says, and it is going to be scripture. that is what they believe in and that is what they're going to follow. And patients don't veer far from that. And not very often do they not go with what their doctor is recommending. I see that a lot of time is going to be the support person or the family member who doesn't live in town that says, hey, are you doing this? Or we need to look at this, or we need a second opinion. But that patient is going to go with what that referring provider and that PCP is going to tell them, because that's the way rural healthcare works.
Other questions? Lori, I was curious, this doesn't necessarily pertain to moving forward, but I was curious how in the middle of a pandemic, you were able to sustain the momentum for this, not specifically related to the pandemic work, and if that created an extra challenge for you.
Well, Shannon was really instrumental in giving me every next step. I had no idea where to start except for with their emails and their initiative to want to really bring this to the patients of Carroll. So it was continuing to communicate with Shannon and Dr. Behrens and make sure that, you know, once we hit one milestone, we moved on to the next. If we were waiting on a federal number or whatever, if I needed information, she helped me go through and fill out some of the forms. So it was really just continuing the conversation and making sure that we were hitting milestones and getting what we needed to move forward. The pandemic really didn't play a lot into it because most of it was virtual, most of it was email. There wasn't a hiccup of lack of accessibility or, you know, not being able to meet with somebody, because we could either meet virtually or we could do most of our communication over the phone.
Thank you. And I see a question. Okay, Shannon. Kim asked, Shannon, are all your affiliates, sub-affiliates at Unity Point? And it sounds like the answer is no.
Nope. And I mean, in Cedar Rapids, we have the Mercy Hospital and the Unity Point Hospital. Both are members. So probably competitors, but for us, they're a team. And I have a question for Lori. I would love to know what your staff thinks. Are they dreading this? Are they excited about it? I know I actually went to Carroll and I gave just a bunch of little talks with Lori's staff. We just kind of did it over the lunch hour, and I gave the same little spiel to different groups of them 4 times. I would love to know after that if you heard groveling or if they were like, wow, this is something that's great and we're looking forward to it.
Well, everybody's always afraid of change and new processes, but you coming in and us educating the staff, they are so excited. You know, one thing that we've had, especially in our infusion area, is oncology certified nurses has really been a goal of ours. And we assure that all of our nurses are oncology certified and that they have that passion and commitment. They know that that is a best practice to at least be screening and having those opportunities. So each one of them is very excited. And they're all a little nervous for when we have the first patient and what that's going to look for them. But as we start rolling this out, everybody's super excited to have this opportunity.
Other questions? Liz, would you be willing to re-share with us the Mentimeter screen that talked about why folks came today? And I wonder if we can just take a moment, and I'll especially ask our speakers, but really anyone, to look through this list and see if anybody has some input or something to share regarding these. How can sponsors support expansion of trials into rural underserved communities? Adding additional trials at an institution. And if anybody typed these in and wants to clarify or add something to what they said for discussion, please feel free to unmute yourself. Let's chat.
I'm very thankful to Kelly and her team for bringing the rural collaboratory together, because I feel like our healthcare in rural Iowa is very strong, and they've really bridged the gap for me as an administrator in our cancer center to give me opportunities and start conversations that I didn't even know where to start. So, you know, being on the work groups and just sitting in on the discussions, it really got light bulbs going in my brain of how can I help? What information do I have for an organization, or how can I be a resource for another center? And then I look to those other centers who have already created something, and how can they help me, and how can they help us grow?
Thanks for that, Lori. And Anjali played a huge role in that as well. And it's really our work group here at the consortium is one of many pieces of really great rural cancer work that's happening. Rachel, I don't know if you would be willing to drop your email address in the chat box. Rachel works with our rural work group here at the consortium. And if anybody is not connected with that group and would like to be, that's a really great, Rachel's a really great place to start. Yeah, so thanks for that, Lori. And we have to share that love, because there's lots of folks around here who are doing rural work. Anything else from this Mentimeter slide here that anyone wants to provide input on?
Shannon, I was going to ask, like, is expansion part of your plan, and kind of what does that look like?
Our plan is, you know, we're a nonprofit. We're here to serve. And so if we have, you know, hospitals, administrators, physicians, communities, whomever it is interested in joining our practice, we want that to happen. You know, we grow as the interest grows. You know, I actually started, and we're a small staff, there's 8 of us. And, you know, I started in this practice a long time ago as a research nurse, as a research coordinator, and we have definitely grown since then. You know, just even the volume of patients that we put on trial in a year's time is significantly different than when I was a research nurse and started 15 years ago. So I really think that it's not necessarily, I wouldn't say that, you know, when I set goals for us as an organization, that it's a goal that I have to grow, but it's definitely, you know, we're here to serve. So if there's interest, then we make it happen. We find a way, we get creative, we hire new staff, we, you know, even adding, when I was doing, our funding comes from federal funding from the NCI. So when I was doing our grant this year, I was talking about how we were adding St. Anthony. I mean, this is, for Iowa, this is the population that we can serve. You know, there's a lot, the NCI wants to expand. They want to see people, you know, sites enrolling minority populations. Well, the best minority population that we can accrue in Iowa is the rural community, and NCI does consider that an underserved minority population. So, you know, anything that we can do to, you know, just let others know about that clinical trials are, I mean, it's my passion, so it's so easy for me to talk about it, but, you know, we just want everyone in Iowa to know that the opportunity is there, and that hopefully that they can do it close to home. So.
Well, and speaking of planning, I think that's a really great question, Rachel. But everything that we've heard you, Shannon, and you, Lori, say today is just so in line with the goals and priorities in the cancer plan, the Iowa Cancer Plan. I mean, I think that's so exciting because, you know, we're looking at and I just put the link in the chat if anybody wants to pull it up, but we're looking at a 2018 cancer plan is when this one started, and everything that you're saying is just beautifully implementing the priorities that were identified for clinical trials within the cancer plan. I just think that's so exciting. So I know it's not specifically your plan, Shannon, for your organization or for you, Lori, but how awesome to be doing something that's, you know, improving cancer control for the state. I think that's really significant.
When Shannon came and did our education, she talked a lot about everybody who participates makes a difference. Mm-hmm. So every time we can get a patient signed up and part of a clinical trial, their ability to do so and the team's ability to make that happen is going to make a difference for the patients down the road. And that's going to only make the care that we provide in the future better and more complex, and we can cure people and give people some opportunities that maybe they wouldn't have had today. But each of those patients is going to help make that happen. And, you know, I think communicating that to our patients too, is that you make a difference by being part of this, and you make a difference by wanting to participate. And you're going to help those in the future.
Sounds like collaboration to me.
Kelly, I wanted to take the time just to introduce myself. And again, thank you so much for the opportunity to be involved in this. I'm Rachael McCaleb. I'm a medical liaison with Pfizer, and I have my colleague Nisha is also on the call. So, you know, for us, we would just like to figure out ways to collaborate and learn more about your needs, especially clinical trials in the rural community population. So I can put my email into the chat, but you know, this is a great opportunity to kind of learn more about what you guys are doing, Laura and Shannon, and figuring out ways that we can collaborate as, you know, an industry partner to expand clinical trial options, especially in rural Iowa.
Thank you, Rachael.
Thank you, Lori and Shannon, so much for being willing to take time to share your experience. Just appreciate that, and both of you so much. Thanks for all you do for Iowans, and for sharing with us today. These roundtables are put on, as many of you know, by the Iowa Cancer Consortium's Research and Clinical Trials Work Group. Those of you who have an interest in this area, I would encourage you to make sure that you are an Iowa Cancer Consortium member, which can be done for anywhere from $0 up to $250 for an organization. But we don't ever want financial money to be a barrier for membership, so you can just join for $0. But that keeps you connected to the whole network, and then also this work group and any other work groups that you're interested in. Thanks so much.